Hey guys, we're going to finish up the last 5 questions for the ANCC sample test for November of 2019, starting with question 21. All right, number 21, an 80-year-old male patient with dementia requires long-term placement. To which funding agency does the patient apply after quote-unquote spending down to qualify? So, again, this is one you're going to have to know. But we'll go over this real quick. So our 4 choices are American Association of Retired Persons, the AARP. That is not a federal agency. That's just an advocacy group, completely for profit. And you get mailers once you turn 50. Second one is Medicaid. Medicaid is a state-funded agency to take care of the poor. Medicare is a federally funded agency to provide health insurance to people who are retired or disabled. And then last one, United States Social Security Administration. Social Security provides benefits to people over the age of between the age of 63 to 67, depending on when they retire, but it does not provide healthcare insurance or any medical benefits. This is just purely we give you money because you're disabled or retired. So we know that this one and this one are thrown out. So it's Medicaid or Medicare. Okay, Medicaid is the correct answer because remember, Medicaid is to take care of the poor. That's why we have to spend down. So people who approach a certain age typically have assets, such as, we bought our house 30 years ago and we paid off the loan 10 years ago. I have a house that's worth $300,000. Granted, I have the difficulty paying for the heat or my groceries, but I still have an asset that's worth $300,000. If you anticipate that your retirement benefits after you retire are not going to be very high, that you can only afford like Medicare Part A, and you're going to be struggling to make ends meet once you retire, looking forward, you should think about getting rid of your assets, such as, in the case of a house, you would go ahead and sell your house to your daughter or son or family member, and with the understanding that you would still be able to live in the house, but it would be transferred to your family's name, not not your personal assets. This thing with stocks and bonds and what have you, so that your total assets are fairly close to zero. Then when you are asked to apply for Medicaid, they will look at all your assets, find that they're zero, and your only income is going to be Social Security or maybe a small pension. That they say, oh, well, now you qualify for Medicaid to assist with medical expenses. All right, number 22. Goals set forth in Healthy People 2020 by the Department of Health and Human Services should include which ones? Elimination of health disparities, empowerment of health delivery systems, increase in lifespan of older adults, and treatment of acute diseases. So as you guys probably remember, Healthy People 2020 has been around since I was in nursing school back in the 1990s. One was Healthy People 2000. The focus on this is to eliminate health disparities and increase the lifespan and quality of older adults. So looking at this, it has nothing to do with empowerment of healthcare delivery systems. It has nothing to do with treatment of acute illnesses. They want to eliminate health disparities and increase lifespan and quality. That's why C is not correct. Increase in lifespan. They want lifespan and quality of older adults. So the correct answer is A, elimination of health disparities across the board. Number 23, based on the individual's culture, ethnicity, and personal choices, the nurse practitioner can optimize the therapeutic partnership with the patient by A, assuming most patients want to rely on family members or care providers and make treatment decisions. B, communicating with the patient using minimal to no medical terminology. C, developing the patient's communication skills to a more advanced level, or D, tailoring his or her communication style to the patient's preference. Okay, let's look at this one a little bit. So, this is a therapeutic communication question. How do we communicate with our patient effectively? So, first one, assuming most patients want to rely on family members or care providers to make decisions. The old Benny Hill joke, we never assume because it does what? It makes a ASS out of you and me. Never assume. Never ever assume. So this is a broad blanket statement. We know that one needs to be tossed out. Second one, communicating with the patient using minimal to no medical terminology. So basically it's asking you to, on every patient, don't use any medical terms. Don't, basically grunts and pictures is what they want. And we know that is not correct. We know that some people are actually, quite a few people are actually very astute and up with medical terminology just from being around the healthcare system, being ill. So we can't assume that they know nothing about medical terminology, and just using grunts and pictures is not going to work. The next one, developing patients' communication skills to an advanced level. This one means that, hey, I'm going to give you a class on medical terminology and spend 45 minutes to an hour every day trying to get your communication skills up. Some people just are not that intelligent. I'm sorry to say that, it's just the way it is. And, trying to increase people's communication skills to an advanced level sometimes is a fuel game. It's not going to work. So the correct answer, of course, is D, tailoring communication style to the patient's preference. You are an intelligent person. You have gotten your master's or DNP. You know how to communicate. You know what's going on. Now you have to tailor your communication style to that of the patient. Will it be high functioning, low functioning? You can do it because you've been taught education. You've been taught how to communicate with people of differing education levels. So that D is the correct answer here. Number 24, which clinical scenario does the nurse practitioner evaluate for quality improvement process change? So it's asking which one of these four do we need to implement QI process change? And Barclay has said in the past, you will get several questions about QI. So what do we need to focus on to have a system-wide or a department-wide change to promote better outcomes? So a new case of necrotizing fasciitis in an immunocompromised patient. Okay. Do we expect necrotizing fasciitis in someone who's immunocompromised? Yes. And it's a new case. So one dude developed necrotizing fasciitis. So does that need a system-wide change? Probably not. Number 2, a projected increase in the number of flu cases requiring hospitalization. Okay. We look at this one. Is that something that we can affect in-house? So what can we do in the hospital to reduce the outside population from developing the flu? That's not something that we can do a quality improvement on in our department to reduce the number of hospitalizations. So we know that is not correct. Third one, an expected rate of ventilator-associated pneumonia in COPD patients. Okay, this is expected. When you look at the numbers, I expect X percent of COPD patients who are intubated will develop ventilator-acquired pneumonia. If the expected rate is 5% and I see 5%, that really doesn't need a quality improvement. I mean, we can always work on it, sure, but we're already at the expected level, and that really doesn't need an acute evaluation. And then the last one, an increased incidence of post-op sternal wound infections. So in this one, we're looking back at the numbers and we're seeing, Dr. So-and-so is, who's a cardiothoracic surgeon is having a lot more sternal wound infections than other people, and versus other facilities in our healthcare system. What could be going on? That would require an evaluation for quality improvement. Is something going on in the process that's making people more susceptible to sternal wound infections? So that would be the correct answer, D. Okay, and last one is another statistics and quality improvement question. A root cause analysis of a crisis situation in the ICU has identified a lack of clinician-family communication as the basis for the resulting adverse outcome. So basically, there was a argument, let's just say, between the family and the medical staff in the unit, and something bad happened. Okay. As part of the performance improvement plan, the nurse practitioner is asked to develop evidence-based policies to establish clinician-family communication standards in the unit. Okay, so again, we're looking for evidence-based policies. That is what we're looking for. These policies should include: 1, an evaluation tool to assess the healthcare surrogate's decision-making ability and anxiety level. B, guidelines for having discussions with family members that are geared toward establishing treatment goals. C, limits on the number of consulting services utilized to prevent sending mixed messages. And the last one, D, requirements for a formal family conference within 12 hours of a patient's admission to the ICU. Okay, so we're looking for evidence-based policies to enhance communication. Okay, so we look at A, evaluation tool to assess the surrogate's decision-making ability. So basically we're giving them a test to see how freaked out people are by seeing a family in the unit. That's not really going to fly, let's just say. We want to develop evidence-based policies to establish standards. Okay, so everyone should act in the same way. This is more of an assessment tool. That's not going to cause people to act in the same way. So this one would be out. All right. Next one, guidelines for having family discussions with family members that are geared toward establishing treatment goals. Okay, these are guidelines. Okay, and we're trying to do standards. So everyone is treated the same, and the staff should follow guidelines to have discussions. So that would be a possible one. The next one, limits on the number of consulting services utilized to prevent sending mixed messages. No, we don't want to limit the number of different services to come in to help us treat the patient. That is not evidence-based. That's not going to create standards, good standards, and nothing to do with communication. So nope. Now you could say that part of the guidelines would be to have, the care team, a designated member of the care team talk with the family. That would be more of a clinician of a communication standard and guidelines, but this is an absolute limit. We can only have two consultants. Well, they may need more. That just won't fly. So we know that we can toss this one out. Okay. And then requirements for a formal family conference within 12 hours of a patient's admission to the ICU. Okay. Possibly this one. I mean, we're establishing communication standards, and the standard is requirement for a formal family conference. So that's a possibility. So let's look at these two possibles. So we have the requirements for the formal family conference within 12 hours. And then we have guidelines for having discussions with family members that are geared toward treatment goals. So you can see, just reading the two, which one sounds better. Here we have guidelines. Part of the guidelines is having discussions with family members, establishing treatment goals, versus you got to meet with them in 12 hours, and that's it. So this is more inclusive, and that is the correct answer. That would be B. All right, and that's the end of our 25 sample questions. Again, I ask you guys if you have any further test questions that you'd like me to go over that are sticking in your craw, you can't get your head around, just let me know. You can email me or message me on this channel, and I will try to get to it as quickly as I can and post something. Thank you very much.